Luis, I did not understand a lot of this. This was probably Portuguese, if I am correct. This the language that was spoken. So I didn't understand it, but the last part of it I did understand was Sunil Rana, and so I thought it is my time to come into the show. So a very good
Thank you.
afternoon from India, but a very good morning to everybody in Brazil. This may be a very beautiful morning in Brazil. This is about a Mayan institution from where I come. I come from an institution which is in the lap of Himalayas in northern part of India, and this is a picture of Mayan institute. Now, uh, basic crux or the basic point of discussion for this particular webinar is: has India been successful or has India been partially successful? And if it has been partially successful, what have been the probable reasons for that? We will talk about certain highlighting points or talk of certain points which may have worked in India's favor, despite the fact that we did have a lot of casualties and we didn't do as well as one would have wanted us to do. But that has been the case with regard to this pandemic across the world. None of the countries across the world can claim 100% success as far as this pandemic is concerned. So therefore, looking at India's success in the larger gamut of how the entire world has fared as far as this pandemic is concerned, is something that can be helpful to all low and middle income countries across the world when they plan to mitigate the impact of a pandemic like this in future, or for that matter, when they are planning to get rid of this pandemic at this present point in time. I do accept the fact that we have lost lives, but we did have some partial success. At least now in the second part of the pandemic, the way our numbers are throwing up, the way that India's numbers are throwing up, we had some 12,000, 13,000 cases last day. We have been having such number of cases for last 2 months now, and large part of the states, large part of the country are not showing high numbers. If you look at the map that India has, and if you look at the numbers that come in India, most of these are restricted to few geographical areas. Most of these are restricted to few states only. Rest of India is almost reporting no cases or a very few cases. For example, our capital city, Delhi, is reporting numbers in two digits, very small numbers. But our focus for this talk will be on a state which is as populous as you probably said in your opening remarks, is as populous as Brazil. So we will be focusing on Uttar Pradesh. It has a population in excess of around 200 million people. How this state, which is largely not considered to be high on resources, not considered to be very high on infrastructure as far as health is concerned, been able to keep the numbers to the levels that it has now for a long period of time. So probably that is where we will continue our discussion on. So I just made a small slide for a general view. How exactly does it work? So this is something that I have made. To be very honest and fair with the people who listen about this, there have been few things that have worked in India's favor, and these few things have also worked in favor of Uttar Pradesh as far as this pandemic is concerned. We will talk of those things later, which worked in its favor. We will talk of the things that the government, over a period of time, initiated to reduce the numbers of COVID-19 cases in Uttar Pradesh. So for that, first we will talk of restrictions on travel and lockdown. Now, when India had its first peak, which was earlier in the part of 2020s, the restrictions were imposed across the country in the first part of the pandemic only. So we did see restrictions and lockdowns in country by the end of March 2020 only. But these restrictions over a period of time were reduced. The impact of these restrictions was reduced, and by the end of October and November 2020, we saw that most of these restrictions were more or less removed across the country. The cases in India were falling, and by February 2021, the number of cases in India was around 10 to 11,000, and that's when the problem started. So India, probably in a mode of early celebration, started thinking that we have won over the pandemic and started opening up entirely. We did have small amount of restrictions. For example, schools were not fully open till then in all parts of the country, but by then, we thought that we should open up everything. We should open up offices. We should open up schools. We should open up industries. Then we should open up we should also allow those people who work from home to go back to the offices. what that did was that by May, we were into the second peak of the pandemic, and we started seeing a high number of cases which touched more than 400,000 a day, which we saw the highest levels which touched was around 400,000 a day in India. And most of the parts, including Uttar Pradesh, the state of which I am talking about, went into a lockdown again. Now, this time the lockdown was different from the one which was used in the first part of the pandemic. Now, in the first part of the pandemic, the lockdown was national and was enunciated or was promulgated by the central government or the federal government. At this point in time, every state government was allowed to have their own lockdowns. They have to develop their own guidelines for that. So what UP did was that they planned a lockdown which will have an impact in the sense that a weekend lockdown will be there. So on Friday they will start the lockdown. So Friday, Saturday, and Sunday will be closed down, and Monday morning people can go for doing some amount of jobs. Not all jobs were opened up. In addition to that, the lockdown also ensured that there were night curfews, so that nobody is allowed to go out of his home after a fixed period of time. Initially, it was 7 p.m., then it was extended to 8 p.m., and lately it has been extended to 10 p.m. So the restrictions were there for night movements, the restrictions were there for day movements from Friday to Monday morning, and restrictions on opening and closure of shops were there. They were allowed to open for a fixed period of time, and they had to adhere to the broader guidelines of using masks, as was suggested previously as well. They had to use masks, keep sanitizers at their disposal, and had to use social distancing as a part of their processes. And there was a fixed number of entries that were allowed in a shop. So that is something that was there as part of the lockdown. But very important as part of this lockdown was restrictions on travel from one district to another district of the state, and restriction in travel from one state to another state. So, for example, Uttar Pradesh did not allow everybody from across the country to enter its state. And when it did allow people to enter its state, it had a reason for them to enter. So, anybody who had an emergency situation, for example, his father or mother fallen sick and the child wanting to visit his parents, so he had to get his RT-PCR done and show his RT-PCR test negative result at the entry place to Uttar Pradesh. And if he was RT-PCR negative, he was allowed to enter into the state. And once into the state, he was asked to undergo a mandatory quarantine at his home if he was RT-PCR negative, and if he was RT-PCR positive and he wanted to enter in the state, he had to undergo a mandatory institutional quarantine in the state. So these were the part of the restrictions which continued to stay in effect till very late this year. So in fact, most of these restrictions were there in place till September, when the number of cases in Uttar Pradesh had fallen down to two digits only. In addition to these restrictions on travel and lockdown, one another important thing that was enunciated by Uttar Pradesh government, as also the other parts of the country, was closure of schools. So as I keep saying that one important thing which happened in India across this period of time, that schools mostly stayed closed. Not just the schools, the colleges stayed closed, the universities stayed closed, and most of the teaching and training under these schools or colleges was undertaken at the level of online platforms only. Very recently, Uttar Pradesh has allowed schools to open, but has asked for an attendance of only 50%. So if a class had 30 students, it has asked the teachers or the school management to allow only 15 students to come on a daily basis. Rest of the students can attend the class online. They can stay home and attend the class online. One important thing in addition to this was the fact that people still now till now have been allowed to stay home, and attendance is not mandated for appearing in exams. So, for example, if a student has not attended school during this period of time and is appearing in his exams, he is allowed to sit in his exams despite the fact that he may not have attended classes for a fixed period of time, which is otherwise mandatory for attending a class, attempting exams. So these two things were something that were done anew or afresh as a part of the management of this COVID in the second phase, as also this was done in the first phase. But there are other things that may have been helpful as far as COVID is concerned in Uttar Pradesh. A large part of this could be attributed to the fact that the basis or the construction or the platform for this was laid down by some certain other things that had already been happening in Uttar Pradesh as well as the entire country. So people keep asking me one question. They ask me, that despite being so poor, despite being so poor, how did India go into a lockdown and ensure the fact that its citizenry was able to have its livelihood? So the fact is that there are certain schemes, social service schemes that run across India, and they have been there since long time now. Some of them have started in the late 90s, and they have been extended in the early part of 2000, or as late of 2011 and 2016. Now, what do these schemes do? One of the schemes that I will talk about and I am interested in talking about is known as the Antyodaya Yojana, which means that Antyodaya Anna Yojana, AAY. Now, Antyodaya means the last person on the street or the last person in the country, and Anna means the ration. So, what does this AAY scheme mean, or Antyodaya Anna Yojana mean? It means that a large population of India's people who are below poverty line are provided rations at a subsidized rate. So if you look at it this way, that around 70% of 75% of India's rural and 50% of India's urban population is covered under this Antyodaya Anna Yojana. A substantial part of this rural and urban population, which falls below the poverty line, which falls under the poverty line, is provided these rations in terms of rice and wheat at the rate of less than 3 cents per kilogram, which is very small. So they can purchase these ration at a very small price of less than 3 cents per kilogram, whether they want to purchase rice or they want to purchase wheat or other coarse grains. Other coarse grains that cost little lesser than this. If rice costs around 3 cents, the wheat costs around 2 cents, other coarse grains cost around 1 cent only to these people who are below poverty line. Now, what Uttar Pradesh, as well as the entire part of the country, did was that they extended this scheme, which was already in existence across the country. What they did was that instead of levying some cost on this rice grains or the food grains that are being made available at a small premium, they said that they will provide free of cost rations at the rate of 3 to 5 kilogram per person per family. So 5 kilogram per person per family was supposed to receive free rations through this scheme only. So instead of having to pay for those amount of rations, they will receive these rations free of cost. And this scheme has been extended to September. This was extended to September of this year only. You'll be surprised that around the country, more than 800 million people have benefited from this scheme only. So 800 million people have received free food at the rate of 5 kilograms per person per person per month per family have received this food till September. So that has been one program, that has been one scheme that has been able to help people live through while there was lockdown or where there was restrictions in people conducting their work. Now, in addition to this scheme, which is the AIS scheme, during all parts of lockdown, it was ensured that the agricultural practice. So agriculturists were more or less immune to lockdown. And in addition to agriculture is the fact that small scale industries or small workers were also slightly under less pressure as far as this lockdown was concerned. So the livelihood was ensured through these three schemes. One, the fact that they were extending an existing scheme and ensuring that food was made available to others. Two, the agriculturists were allowed to carry on with their work throughout this period of lockdown. And three, the small workers, the daily wage workers who were working on a plant, who were working on a factory, or who were working on site for construction, they were allowed to go to these places despite imposition of lockdown or restrictions. So this was something that was done anew through extension of the existing schemes, as well as the thought process that ensured that people didn't lose their livelihood during these lockdowns. Now, in addition to this ensuring lockdown, what UP did was this Mukhyamantri Bal Seva Yojana. This was something that was unique to Uttar Pradesh, and no other state probably thought of it at that point in time when Uttar Pradesh envisaged it. Now, what they did was that they thought that anybody or any person, any family who loses their earning member or any kid who loses his father or mother, they are entitled to this Mukhyamantri Bal Seva Yojana. Under this yojana or under this scheme, what do they get is that a child who has lost his father or mother is directly under the patronage of the state, and they receive a financial assistance of around 4,000 rupees, 4,000 Indian rupees per month. 4,000 Indian rupees is roughly, what I would say is around 600 or 60 US dollars, sorry, 60 US dollars. So they will get that on a family basis. Per person will get that from the Chief Minister's Relief Fund. In addition to that, they are giving free support for education. And if any of these is of the marriageable age, and because of the fact that they have lost the earning members, the family is not there to support them in marriage, it's the job of this Mukhyamantri Bal Seva Yojana that this marriage will be done. So this was another step that was taken up by Uttar Pradesh to ensure that people are able to take care of themselves during this lockdown and are able to submit to the guidelines that are being taught from or that are being planned or envisaged from time to time. Because once you have people who realize that their livelihood is ensured, and if there are deaths in the family, they won't have problems with regard to how exactly they will function from now onwards. Their chances of looking up to guidelines or following guidelines or submitting to guidelines and restrictions is much better than if there's a problem with these two issues. The third and the most important thing that Uttar Pradesh did was Mera Gaon Corona Mukt, which was the title of the talk, which is My Village Corona Free. Now, this was something again unique to Uttar Pradesh. In fact, this was started by some other state. The Gujarat state had started this earlier, but the extension and the scale with which Uttar Pradesh launched it was mammoth. It was unprecedented across the country at that point in time. Now, you can imagine the fact that around 70,000 villages in Uttar Pradesh were covered under this Mera Gaon Corona Mukt scheme. And every village was tracked on foot, and these ASHA workers who are accredited social health activists, in addition to ANMs, which are auxiliary nurse midwives, they traveled the breadth and the length of Uttar Pradesh villages and tracked, traced, and tested most of the villages there and in their homes only. So what it did was it did two things. At one point in time, it was able to gauge the amount of pandemic that is there, the amount of impact of pandemic that is there in the rural areas of India and rural areas of Uttar Pradesh. Because it was being thought that even if India is able to take care of the urban areas of its urban areas, it may have some difficulty in tackling its rural areas because the reach of healthcare in rural areas is not of the same level as it is of urban areas in India. So in that sense, this Mera Gaon Corona Mukt village was a great initiative, and these ASHAs and ANMs did a very fabulous job by tracking, testing, and identifying all those who were there in these villages and were probably sick or not sick. So what they did was they carried out screening in their houses through use of pulse oximetry. They carried pulse oximetry and thermometer with them and had a small questionnaire sort of a thing with them, wherein they would ask for recent onset of acute respiratory infections, use pulse oximetry to check for the level of symptoms in terms of oxygen saturation, will look for temperature, if the person had fever or not, will look for other symptoms like cough or other symptoms which were evident of existence of COVID-19. And if they could suspect somebody as being a patient of COVID, they would immediately call the nearest health facility person, and that health facility person will come, test them for COVID-19. And if there was a chance that this person is COVID-19 positive and is sick, and they would transfer him to the nearest health facility. If the patient was COVID-19 positive, but was asymptomatic or had very mild symptoms, so that person was allowed to stay home. Now, what this did was that, in essence, was that it reduced the migration of rural population from rural Uttar Pradesh to the urban Uttar Pradesh. And while this migration stopped, the chances of infection traveling from one place to another reduced. The travel restrictions were more strictly followed because people would get their healthcare needs being fulfilled at their rural level only. So that was probably one of the most important aspects of initiatives that was taken up by Uttar Pradesh through Mera Gaon Corona Mukt. This is just an example of how they tracked these villages and what did they do with regard to each and every detail that is being filled in this form. This is the form for the month of May that was used in the month of May. And you could look this on the left hand side. It is in Hindi. I'm just trying to translate it. This is the name of the block or health area, a geographical area, name of that. Then this is the number of households that are there. And third is the team which has visited and has seen the number of houses there, and how many of these villages they have identified, how many of them have received vaccines, the first dose and the second dose, and how many of these have identified patients with infections, chances of COVID-19 infection. So for example, they have pointed out first in column it's fever. So how many of them have been identified with fever in this particular block? How many of them have been found with acute respiratory infections in this particular block? How many of them have had shortness of breath as far as this particular block is concerned? Or how many of them have had symptoms of symptoms of gastrointestinal symptoms with regard to, in addition to the fact that they have fever. So this all is listed for each block by these ASHA, accredited social health activists, and A&M, and this is submitted to the chief medical officer of the area. So this has to be filled across all blocks, across all villages, and the report had to be submitted to the chief medical officer on a daily basis. And this was a key component of this Mera Gaon Corona Mukt village initiative. So this was some other initiative that was taken up by Uttar Pradesh in consultation with UNICEF. And under this process, what they thought was, this was late in the second part of the COVID-19 pandemic, or second wave of the COVID-19 pandemic, when it was being thought of that the third wave is going to mostly impact the children. So what did they do was that they created a 10-part series or 10-episode series on the impact of COVID on a family. And this was relayed across national televisions and other private channels in Uttar Pradesh, wherein a 7-year-old girl protagonist would talk about the importance of, for example, hand washing with soap in one episode. She would talk about social distancing and use of mask in another episode, engagement and learning during long lockdown. This was a part of the third episode. So this was all a part of Tara Hai Taiyar or Tara is Ready. There were 10 episodes, all of which were being relayed on national television or a private broadcaster who was willing to relay them across Uttar Pradesh. The reach was huge as far as this program was concerned. So this is something that I have thought what every other low and middle income country should be doing if they have to take care of this pandemic or a pandemic of similar nature. So the governments have to involve, and governments have to involve these community-based organizations and village health guides sort of a thing. Create a team which build a community-based team. And this community-based team can be composed of community healthcare worker or community volunteers who are going to do the same job which was done by people in the villages of Uttar Pradesh. Pick up people who may have symptoms and report this to the nearest health facility so that the load on health facility is reduced, so that the load on healthcare workers is reduced. And this is pretty easily done because of the fact that all of us know everybody else in the villages or in our nearest geographical vicinity. So it may not be a difficult job. And this community-based team can be empowered. It should be tasked to create awareness, create participation, organize events which will be able to again create awareness. They should be there to implement decisions in terms of who exactly needs to be taken to the health facility, and this delivery of healthcare can be a basic part of it can be entrusted to them only. Thank you. That's all from my side. If there are any questions, I am more than willing to answer them. I took a little longer time than I was supposed to. I'm sorry for that.
Thank you very much, Dr. Sunil. You can choose the channel, the English channel in the platform Zoom.
Okay, where it is?
So you can follow the next presentation by Dr. Camila Franco.
How do I do that? How do I follow this English channel?
In the bottom of the platform Zoom, in the line bottom, you have a globe. icon
Yes,
with a globe, and you have two options,
interpretation.
three options of English and Portuguese.
Okay, okay, got it, got it, got it. Yes. Okay, English, and I've chosen English. Fine, fine. Thank you.
Pronto, agora.
Okay, good. Can you hear it now, Dr. Raina?
Yes, yes, yes. I'm getting it in English now.
Ok. Muito obrigado pela sua apresentação.
Okay, thank you for your participation, Dr. Raina. Great overview on the strategy to control coronavirus in India with very interesting topics for us to think about. We do have a problem of healthcare community agents, which is also very important. But before we ask questions, let us listen to Dr. Camila Franco, the Undersecretary for Health of the municipality of Niterói in Rio de Janeiro. She is both a health manager and a health professor, and she will definitely add a lot to our discussions. Dr. Camila, you have the floor. Thank you, Doctor. Thank you, Professor Luis Eugênio. Good morning, Dr. Raina. It was a great pleasure to listen to you telling your experience. And while I was listening, I could actually establish several connections of your experience with the experience in the municipality where I am. Our municipality is one with a 500 plus thousand inhabitants, much smaller than your experience, the experience that you reported. But even though regarding the management of the pandemic, we started from very similar assumptions to fight against COVID-19. When you mentioned the lockdown strategy, we had no doubt that lockdown approach would be necessary at the first time, still in 2020, to hold the velocity at which this virus was transmitted. And more than that, we needed time to organize our healthcare system to receive those infected with the virus. So to avoid the collapse of the healthcare system, it was a fight against time. It was only possible because at that time, we determined lockdown with the closure of several productive activities. Only essential activities were kept working with reduced scales of personnel or reduced schedules of personnel, also requesting social distancing, and it decreased the speed of the transmission. It allowed us to get our healthcare system organized, and at no time our system collapsed, although we experienced very hard times, particularly during the second wave, which came with some different characteristics. Our capacity to establish the sanitary barriers. Niterói is a city far from Rio, just across the bay. We are united by a bridge. In Rio de Janeiro is an 80 million inhabitant capital with different characters. So we are not fully isolated. We're not an island city. We are urban, we have large urban areas. And the sanitary barriers that we established, avoiding travels from one city to the other, controlling and restricting traffic, to local residents, was also very important. And I kept thinking, when you mentioned your experience in India, in Uttar Pradesh, how you established those protection strategies for the rural areas, because we know that the rural areas were more vulnerable, not because of geographic issue, but access to healthcare service. Worsening of COVID-19 in a rural area, it's much more difficult to serve timely than when you have the population in an urban area. So thinking about your strategies, the way that you've determined it was very interesting, even in face of a lockdown. And the issue of survival, which you mentioned, that was also a very important challenge for us to have high levels of social distancing and maintain lockdown. We had to ensure the subsistence of individuals, food safety, basic income as well. It was very important. In our city, we also adopted strategies to ensure the subsistence of the individuals based on benefits to the population, such as the delivery of staples basket or food basket. People, and also some cash. People would go to buy food on their own, and some other benefits to establish a basic income so that the population would remain at home. Another concern we had was maintenance of the economy, keeping up with the economy. How could we actually restart the ramp up the economy, the economy, if we didn't care of economic process during the lockdown, during the worsening of the pandemic? And then we established very important programs based on businesses' economic protection, ensuring the maintenance of jobs and employment with direct financial assistance to businesses. So when in 2021 we could restart or ramp up the economy, we didn't have a much larger number of unemployed. It allowed us to flexibilize the restrictions more easily and more safely. This is one of our concerns as well. And I see urban clusters as a great challenge. You know, given the architectural features of our urban areas with very close households, of health care to these areas, and it was a huge challenge for us to stop the transmission, because the first hypothesis was that those urban centers would explode in cases and deaths, given all these features that I've mentioned. So regarding with the tracking measures and active screening, this was very important. The experience that you've mentioned on the community-based health teams, you know, doing the surveys, questionnaire, and testing for symptoms. We started one such program with those professionals we call community healthcare professionals. And many times we would suggest and impose quarantine and distancing and lockdown, but some citizens do not have a place to get isolated. Many times you have whole families within a single room. That's when we created the assisted quarantine centers, facilities established in at schools, larger schools. We've organized the flows and the quarantine center. It was a place to receive those individuals tested positive. They'd had to get away from the family members and then go back to their own communities once they were safe. So these quarantine centers, they were kind of assistance to allow an adequate quarantine. And all these issues allowed us to protect those clusters, urban clusters, those communities, and avoid what was the greatest risk and the hypothesis we had here, that whenever this disease arrived, it would be a huge outbreak. It would wash out these areas, killing thousands and thousands, because these are places where we still have a lot of deprivation, if you know what I mean. From the very beginning, we had very important educative measures on protective approaches. This was quite clear in your presentation as well. The use of masks, washing the hands with soap and water. It was very important. And this is not just a government-based measure. No matter, because, I mean, as managers, we determine that this is mandatory. You have to wear masks, you have to wash. But if this is not understood by the population, if we do not have a wide process of adherence, and which would include a cultural change, it would be very difficult. So we realized a cultural change in our population. Our population adhered to the wearing masks, washing hands, and social distancing everywhere. And it also allowed us to start thinking about some process to get back to normal. The experience you mentioned on this education measures, that the UNICEF project that were broadcasted on TV, those 10 episodes to the whole population, I kept thinking, how could it have been? How could it have been more assertive? How could we have been more assertive if we had had a nationwide coordination in Brazil to face coronavirus? Unfortunately, in our countries, this process was up to the subnational and local coordination, states and cities. So we did have educative or educational measures, but only locally, each city, each state. But it took too long for us to have a country-wide action, such as the one you've mentioned with the 10-episode TV show. I mean, facing COVID is a large educational action. I mean, to be able to get rid of the virus and live free of it depends on a very important educational process combined with a process of epidemiological surveillance and control. So this combination of public health, epidemiology with educational measures is absolutely fundamental for us to be successful. And I kept thinking, what other, you've mentioned the community-based teams, the UNICEF TV episodes, and other educational measures were also implemented throughout the process. You mentioned that you managed to to stop migration from rural areas to urban areas, as you could sanitize or solve the food issues in rural areas and all. Here, we had a very important migration from the urban to the areas to the countryside for a specific characteristics we have in our residences. And in the city of Niterói, it was not different. We did have some migration from the central areas to the rural areas to beach areas. Some people migrated from apartment buildings to houses, many times two houses became only one to ensure some distancing, but that was something that we have observed here. And this way, we had a second wave in the state of Rio de Janeiro, which was observed in the countryside. While in the first wave in 2020, in the state of Rio de Janeiro, we had the largest concentration of cases and deaths in urban areas near the capital city. In the second wave, still in the first quarter 2021, this worsening of the pandemic was in the countryside, was in the rural areas. We had a much worse situation in healthcare services. The healthcare services were already stressed from over 1 year of a pandemic, and in the rural areas we have more constraints and limited access to healthcare. And in the end, I would say that, there's also this issue of schools. You mentioned that schools and colleges were started to reopen this year, 2021, between August and September. And then I kept asking myself, for how long were they closed for presential classes? What were the strategies applied in the educational process of students, especially when we talk about the early grades, such as 3 to 7-year-old children? How was this educational process there? In Brazil, we already have studies pointing out a lagging 10 years, or getting back 10 years in education, given this closing of schools. In our public school networks, we didn't manage to have a proper transition from presential to distance learning. And, those children were unassisted. It produced important educational losses in this historical process that Brazil had already been faced for a while. So this is something that we will have to face and deal with, in the next months and years, how to design the Brazilian educational process in order to rescue and recover this process that was somehow lost. I'm not saying that there was another way of doing it. We shut down schools at the right time. We couldn't have any other way. We reopened, and then each municipality, that was not a nationwide coordinated action. It was up to cities and states. Each city, each state had its own process of reopening schools, and all according to their own assumptions and criteria. Here in Niterói, we shut down schools on the 14th of March 2020, even before the first wave reached Niterói. On the week we detected the first case, we shut down schools. We started reopening schools in October for higher grades, for middle and high schools. And in February 2021, we restarted with the early grades. Throughout this year, we had some shutdowns punctually, but always trying to understand education as an essential activity as well. Still, late last year, with a good understanding with the crisis cabinet and the scientific committee, we understood we needed to reposition schools and education as essential activities. So we could shut down other activities and other sectors according to the needs, but we had to keep education with some degree of presential activities in place. For that, we created very strict protocols for schools, for universities, for families and students, and more than that, we put together a school surveillance system to control every case or suspicious cases on schools, with a process of very quick tracking and screening, isolation, and if necessary, shutting down schools during this quarantine period. And this is the last report this week. We didn't find any case of COVID in schools. But when you find cases, transmission was not did not take place at schools. It took place elsewhere, and then the student doesn't even get to come to school. That's how we reopen the process. Now we are going to take another step, which is restarting activities at school 100%. So the repositioning of education was fundamental to have a quality education at distance, which is a reality that we live in our country, especially in the public educational system. And then once again, we talk about the need for community participation. So how can we re-uptake this process at schools? Because it is only possible if I have the whole school community together, students, school managers, teachers, professors, and families as well. So it is only possible if everyone is aware of it. And so in the protocol, if the child has, a stomach ache or a cough, if there's contact with any person suspicious of being infected, he won't come to the school. So it has to do with a social awareness and empathy process that we had to develop in our community. The other thing is that the same process was implemented to restart other activities. Walking towards eliminating coronavirus is also walking towards a process of sanitary collective awareness. We must understand that each one of us residing in the city is responsible for holding out the coronavirus in the city. That was the assumption we applied to the whole process throughout this near 2 years of communication with the population, with productive sectors, with workers, and also in the educational sector. I believe we are walking towards that. Today, we have 6 days without any death from COVID in the public healthcare system, a very significant decrease. A municipality, a city that had already had more than 150 patients hospitalized. Today, we have less than 30 patients hospitalized. Transmission still takes place, but in a very reduced way, and decreasing every week the number of new cases and dramatically decreasing the worsening of cases. All this combined with vaccination, with a very daring, very aggressive vaccination strategy. In our city, also, despite the nationwide coordination of the vaccination process, we managed to advance, and tomorrow we are completing the vaccination of individuals above 12 years of age, the third dose for above 60 and healthcare professionals. And with this, next week, COVID vaccination will be incorporated in our vaccination program. It will no longer be this punctual action that require a lot of effort from managers and professionals and many healthcare units, working 24/7. It will be incorporated in our vaccination immunization routine. But respecting the population that showed a great adherence to our immunization campaign, both in first dose, second dose, and it is with this collective spirit that we will be able to eliminate coronavirus and defeat this pandemic. Thank you. Thank you, Camila. Great talk. Not only provocative in terms of, assessing the Indian experience, but also on Niterói experience. Congratulations, and this capacity to align this management with the participation of community is fundamental. This is quite clear both in the Niterói and the Indian experience. We already had some question asked through the chat tab, but before asking questions, I'd like to ask Dr. Raina whether he would like to comment on those many questions mentioned by Camila. Sunil, Raina, would you like to comment or ask questions, whatever?
Yeah, thanks, Lois, for inviting me at this point in time. I was listening to her, and it was an engrossing talk, to be very honest. It was clear. Now, most of the times, where we commit mistake as public health specialists or those who work in the field of public health, we make mistakes that the models for better healthcare delivery exist only in the rich and elitist class. So the best model across the world will be delivered to us by those who have the highest amount of resources or who are tech savvy, who are the technological advantage. We tend to forget that within the resource constrained people, within the realm of resource constrained societies, the chances of having a model which is sustainable are more likely than those who have higher resources. So when I listened to Camila, I could understand that within those limitations that are similar to probably Brazil and India, they could develop some models which could be universally applicable. For example, the student surveillance system, which is very good, because at the end of the day, we will need to decide whether we want to take students to school without vaccination or not. We need to probably understand the difference between risk quantification and risk mitigation. And therein, we will need to take the students to school without having them vaccines. When I talk of India, so if I have to vaccinate my children or my kids in India, I would need, how many doses do I need? If I am using a 2-dose vaccine regime, I would probably need 1.8 billion doses, which is huge numbers to take care of. So it will take me many, many months to deliver those. So do I take my students to the school before that, or do I wait for that? So if I have to take them to school before that, I will need to have something which you people have developed there in Brazil. So probably this story needs to be told across the world. Stories like these, which are workable in resource constrained settings and can be replicated across the world, than models or stories coming from rich countries, which are not replicable across the world. So probably that was one of the key takeaways from this talk. Exceptional. Thank you.
Muito obrigado, Sunil.
Thank you, Dr. Raina. I would like to bring 2 questions that were asked here. The first one has to do with the existence of positions that are opposed to these measures, whether or not there were resistance from the political sector or the economic sector against these measures, such as entrepreneurs or businessmen or political parties, political groups, whether or not there were great resistance against these measures, such as was the case of Brazil. In Brazil, there was a lot of political discussion against any lockdown measure, any restrictions, including the wearing of masks. Did you see this? Did you witness that in India as well? That would be the first question. A second question has to do with the previous existence of a primary care system, strong, robust in India. Whether or not it existed before or it was only put together from the COVID-19 pandemic emergency. In this case, how does primary care take place in India? Did it work before the pandemic? Whether or not there were specific changes for the performance of community-based teams? I'm not sure the questions were clear enough. If you didn't understand, let us know. I'd like to hear you about this, Dr. Raina.
Thank you. First, we come to the first question. I have a belief that it's much more easy to talk to politicians than to scientists or doctors who turn bureaucrats or who turn to think that they are advising the politicians. So the difficulty with the current system across the world that I feel is that a group of people who think that they're advising the governments, they think that they know everything. And this fact that they know everything about the pandemic, about the healthcare crisis, is something that is not delivering the right message to the politicians. Otherwise, if politicians are told the correct things, if they are told the correct messages, if they're allowed to think on their own, that this is my take on it. If they're allowed to think on their own, it is much more easy to convince them. Now, luckily for India, what we had was we had a prime minister who was more or less convinced on lockdown, and he was more or less convinced to take it to everybody in the country. Now, what I mean by that is that if we would listen to, we started in March, in the end of March, we started the lockdown when the number of cases in India was 500 only. Before we went on a nationwide lockdown, we went on a self-curfew or Janta curfew, which the Prime Minister initiated. He said that let us impose a self-restriction on ourselves to stop moving from our homes for one day. So for 24 hours, he said that how many of you are willing to listen to me and they don't move out of their home. This was probably on 22nd of March. So this was probably a rehearsal to getting into the lockdown. And then we went into the lockdown on 25th. So the politicians being convinced and being able to convey it to the people is probably the key. Because believe me, people generally tend to trust politicians if the politicians are delivering the correct message more than the scientists at any point in time. So the key was that what I always say when I talk about this is that India followed more or less a circular system of communication. It didn't follow a top-down or bottom-level communication system. So it was not that communication came from the bottom level and it was communicated to the Prime Minister, and Prime Minister communicated it through his ministers or bureaucrats and then to state level officials, and these state level officials will talk to the lowest level of official and then to the people. No, it didn't work like that. Here, the Prime Minister was directly talking to people on a daily basis. You would be surprised. You would see hear the Prime Minister's voice in the telephone messages that you would send to each other. So if you would call me, for example, from Brazil, you would not hear my voice first. You will hear the voice of my Prime Minister, or you will hear the voice of a politician, or you will hear the voice of a celebrity who will talk of vaccination, who will talk of lockdown. For a major part of it, when the lockdown was lifted, the one voice that rang in our telephones was that of our Prime Minister. It said that the lockdown has been lifted, but Corona is still there. So probably the way messages are delivered and the way messages are carried down to the bottom is the key as far as response of the people is concerned. The success of managing this pandemic, not just this pandemic, also the fact that we have been able to achieve good success as far as vaccination is concerned, is that people submitting to guidelines and trusting the intent of the government is something that is very important. And that is probably where India was helped. We did not have street level agitations on that. Why should there be a lockdown? People more or less accepted lockdown as something which was necessary and important to keep down the pandemic. So at no point in time had we have problems with people refusing lockdown, neither the industry, nor the common people, nor anybody else. So all of them submitted to lockdown as if this was necessary because of the fact that probably it was conveyed to them in a very correct way, or it was conveyed to them on a daily basis from top leadership down to the basics. So that was something that helped India probably. The second part of your question, the second question was about primary healthcare system. How does our primary healthcare system work? Now you need to understand it this way. Now India at this point in time has around 28 states and 8 union territories. Union territories are something which are directly under the control of the central government or the federal government. The 28 states are ruled by their own state chief ministers, which may be of any party, which may be of the same party which is ruling at the central government, or maybe of different parties. Now, these 28 states and these 8 union territories have around 600 medical schools or medical colleges. That's what we refer to in India. And that is probably forms the tertiary care setup that we have in India. in addition to the private health system that we have that works as far as tertiary care setup is concerned. Then there are district level hospitals, which are again secondary and tertiary in their outlook. They deliver both secondary and tertiary care. Then below the district levels, we have the sub-district levels or community health centers, which are known as the CHCs or the sub-district hospital levels facilities. Now, these community health centers across the country, if you look at, they are in excess of some 3,700. So they are a huge number again. These are at the block level or wherein the population ranges from between 80,000 to 120,000. So they are that placed at that level. Below a community health center is a primary health center. Now, this primary health center is supposed to deliver the primary care that you were talking about, as also community health centers do also deliver primary care. So every state has huge number of primary care centers. So if you look at a country, the number of primary care centers may be in excess of 35,000. This is the number of primary care centers that we have across the country. Below the primary care centers, we have the sub-health centers, the SHCs. So every primary health care center has around 4 to 5 sub-health centers under this. Now, these sub-health centers deliver preventive and promotive care for a population of around 5 to 10,000. The PHC is manned by a medical officer. So you have an MBBS doctor who sits at the level of primary health care center, which takes care of around 20 to 30,000 of population. Below the primary health care, we have primary health center, we have the sub-health center, and sub-health center is manned by an ANM, which is auxiliary nurse midwife or a health assistant. So they are paraprofessionals who work in these sub-health centers. Now, in last 3-4 years, what we have done is that across the country, we have launched the universal health coverage through what is known as Atal Bihari Pradhan Mantri Jan Arogya Yojana, ABJ, Atal Bihari ABJMAY. This is something that we have done in last 3-4 years. Now, under these, what we are doing is that we are converting these sub-health centers, which are at the population of around 5 to 10,000, 3 to 5,000. We are converting them into health and wellness centers. So across the country, we are developing 150,000 health and wellness centers. Now, each health and wellness center will be manned by a community health officer. So CHO or community health officer. Now, these community health officers are nursing professionals or nurse care practitioners, who undergo a training of 6 months to be able to deliver healthcare at the level of these health and wellness centers. So the government of India is funding all of this program. These 150,000 health and wellness centers across the country are being developed through a program developed by the government of India across the country. If you go below this health and wellness centers, you have the village levels. And roughly a village is the population of around 1,000 people. This 1,000 people is being delivered by or taken care of through these ASHAs or accredited self-help social health activists, ASHA, which I talked about in my talk also. So these ASHA workers deliver basic health care at the level of villages only, village level. And it takes care of around 1,000 people only. So not beyond 1,000 people. So below sub-center are these ASHAs, as also other healthcare workers who are not directly a part of health. For example, village health and sanitation guides are there at the level of village, who take care of public health in terms of providing sanitation. So they are again a part of the system, but not directly a part of the health. But ASHA is something which mostly deals with health at the village level of the village level of each village. So across the country, if you look at my state, which is much smaller in number, it has around 707,000 ASHA workers across its villages. If you look at Uttar Pradesh, which is much larger, much bigger, it has around 170,000 ASHA workers who are spread across the villages. So the number of ASHA workers spread across the villages is huge. This is all a part of the scheme which was developed to deliver healthcare at the level of primary care only. So they don't treat patients, these ASHA workers, but they take care of, for example, identification of COVID patients was given, the duty of identification of COVID patients was given to them. Or we give them the task of identifying active case finding in terms of tuberculosis. So they go house to house and search for active cases of tuberculosis. or they are asked to screen people for blood pressure, or they are asked to screen people for raised blood sugar or diabetes or hypertension. So this is something that they do at the village level. Take them to the sub-center level or health and wellness center. And beyond the health and wellness center, you have the PHCs, which are manned by the healthcare professionals. So probably this is how our primary healthcare works. And this has always been in existence. That is why I said at the initial step itself, that India may have been helped by the fact that over a period of time, it has built a system which was robust in a sense to deliver in the pandemic. So the success of being able to reduce the number may not be given to the on-hand management of the current pandemic, but also to the fact that over a period of time, we built a system which was able to take care of this pandemic. I give another example, which may not be directly related to it. Now, over a period of time, for example, when it started for the first time, the only facility that could deliver RT-PCR testing in India was one. So that was in National Institute of Virology. So we had only one testing facility. But over a period of time, what Government of India had done was it had started the viral diagnostic reference labs, research labs across medical colleges in India. So roughly 120 medical colleges in India had these VDRL labs, which were established by Government of India, as also multidisciplinary research units, MRUs, which were established across another 100 medical colleges in the country. I'm in charge of one of these MRUs in my medical college. Now, once the pandemic came, these labs were strengthened to do the testing as far as RT-PCR was concerned. So we could escalate or we could scale up the number of testing or the number of tests that we started initially to high numbers because we had these in place, because we had the VDRL and the MRU in place. So probably the fact that we had the advantage just because of the system was built prior to the pandemic and we could use that system may have been of an advantage to us. I hope I have been clear on this.
Muito obrigado, foi muito esclarecedores.
Yes, thank you. Quite interesting. Your information was quite clarifying. I would like to ask a question now to Camila from our participants. Camila, what factors do you believe were responsible for the great adherence in Niterói, even in face of lack of nationwide coordination? The main factor was mentioned recently by Dr. Raina. It is the trust of the population on the leadership, on the government leadership. But despite the lack of nationwide coordination, we undertook this responsibility to communicate with the population. So on the same day we determined lockdown, we established a crisis cabinet. This crisis cabinet included different secretaries led by the mayor, and it would gather on a daily basis to assess the conditions and establish the actions. And in the end of this meeting, we held a meeting with the population online. So daily, the mayor and the health secretary would communicate with the communities, reporting our conditions as well as actions, inviting the population to face COVID collectively. So I have no doubt that trusting the government leadership was a determinant factor for the population to actually believe that we were all together in this struggle. It's what Dr. Raina said. The population heard the voice. Heard the voice of the prime minister he mentioned. But here, the population heard the voice of the mayor on a daily basis. The mayor would say, we need to do this and that, and together we will be able to overcome COVID. So this position of collectively we will, together we will, it drove this great adherence by the population. So I have no doubt that the communication process was fundamental. This together with the social protection and safety measures. So a collection of activities that allowed for the development of this trust process. And when you mention measures against the lockdown, we witnessed this in Brazil very strongly. In our city of Niterói, we had very little movement, but very little movement against lockdown. We didn't see resistance against shutting down activities, though. Activities were stopped at the right times, and when they were restarted, they restarted with restrictions, with protocols one by one, not all at the same time. The latest productive activity got back to normal on the 1st of October, over 1 year shut down. So in this process, economic sectors also had weekly meetings. So weekly restaurant sector, the private healthcare sector, each sector had their their own weekly meetings where they would hear one another, about their difficulties, and at the same time we would open a channel of communication with the leadership, and from this some policies and economic protection strategies were adopted, and that's what allowed the sector to join the strategy. And then we already had this communication channel with the different sectors, when to restart, how, what protocols, what protection measures. Everyone joined in, everyone adhered, both the productive sectors and the population. So they were also responsible for the maintenance of their economic activities. In case indicators showed a worsening of the pandemic, the activities would be restricted again. So this co-responsibility was fundamental. And this collective construction of partnership led by the local government creates trust. I have no doubt that this trust is a very important issue in the adherence of the population to the different measures implemented by the government. Thank you, Camila. Very clear also. We have another question to Dr. Raina. Actually, we have two questions, Dr. Raina. The first one is about access to rural areas. Was there any greater difficulty, and what strategies were applied to get information and services to the rural communities? And the second question is about vaccination. How is vaccination going in India? Was it okay, peaceful? Are there anti-vaccine movements that are preventing a good performance of the immunization campaign? Please, Dr. Raina, you have the floor.
I think the second question will answer the first as well. So how has been the vaccination in India? I think vaccination in India has gone well. And for a large part, our limitation with vaccines was that we didn't have a finite supply. We didn't have an infinite supply of vaccines. The supply of vaccines was finite and it was fixed, and we were building on the vaccine capabilities as far as vaccine delivery was concerned. You may be aware we had largely two vaccines to rest on. We had the Indian-made Covishield, and we had the, again, Indian indigenous vaccine, which was the Covaxin, which was being delivered in India. Now, the capacity of both these companies to deliver vaccines on a monthly basis was not at the highest level in the initial phase. And it was only, I think, by the month of September that we did have the manufacturers of Covishield being able to deliver us around 200 million vaccines in 1 month time. So in that sense, we did have difficulties as far as vaccines were concerned, but vaccine supply was concerned. But as far as delivery and execution of vaccination was concerned, it was not a difficult job. Primarily because of the fact that we probably run the biggest, India probably runs the biggest vaccination program as far as kids are concerned. So we have been very successful with running our vaccination program for our under 5, and building that on an experience from that was huge for us. We didn't have anti-vaccine problem in India. Nobody opposed vaccines. In fact, people wanted to have vaccines as early as 16th of January when we started. People did want to have vaccines. I think that we need to understand vaccines in one term. That's how I understand vaccines now, because as I said, I have been involved with vaccination part from day one in my institute also. I was in charge of that. I continue to be in charge of the vaccination process. So we need to understand vaccination in these terms. When the deaths go high, or when the number of cases go high, the demand for vaccines is the highest. When the deaths go low, or the number of cases go low, then the demand for vaccines is also low. So this is something that works probably what we define as the precautionary principle. People fear death, people fear the default setting, then they look for everything. Vaccines is probably the biggest tool in their hand. So we have been able to deliver vaccines across the country. And a few days back, I was on a television channel in India. I said the best part of India's vaccination program is the equitable delivery of vaccines. So across the world, we see problems that there is difficulty in being able to deliver vaccines to some sections of the society, some parts of the country, some geographical areas of the country. In that sense, we didn't have a problem, because you will be surprised that the distribution of vaccines in India has been more or less uniform. 60% of vaccines have gone to the rural areas in India, while only 40% of vaccines have gone to the urban areas in India. So we have more or less a uniform distribution of vaccines, although we would have wanted it much better, because 70% of our, almost 70% of our population lives in the rural areas. So I would have wanted more higher numbers as far as rural areas is concerned. But still 60% is good number. This has probably been helped by the fact that also that the vaccines are being delivered free of cost in India. So all of us are getting our vaccines free of cost, and they are being taken to the places wherein these vaccines are delivered. You'll be surprised that in one of the areas that in the state wherein I live, one of my areas is not accessible through road. It has to be accessed for a very short period of time. It is available to be accessed through road. For the rest of the time, it's closed for access through road. So the vaccines there were delivered by heli-taxis, and the vaccines were delivered by the district collector, or what you would like to refer to that in Brazil is district governor, something like a district governor, the official head of the district. He himself went into that helicopter and delivered the vaccines to that place. So probably in that sense, vaccination has been good, and we have been able to cross the 1 billion mark. We are close to 1.3 billion now. Large people have received the first dose of vaccines. Around 30%, 30 to 32% people have received the second dose of vaccine. Those who are eligible have received the second dose of vaccines. So in that sense, vaccination is good, but I still feel that the vaccination will need to take care, we need to go up. The production has to go high if we are able to deliver vaccines to everybody in India, because the numbers are huge. And we are still not thinking of the third dose, what people refer to as the booster dose. I generally don't want to agree with those words, the boosters or the third dose. So we still have not thought about the third dose. We are currently focusing on delivering of vaccines to kids, and in fact have given authorization to three companies to deliver vaccines to the kids. And we may be starting vaccination of kids very soon, wherein one of the companies will be giving vaccination to children about 2 years of age, and another company is going to deliver vaccines to kids between 12 to 17 years of age. So that's something that is in the pipeline. Initially, you are thinking of targeting kids with a comorbid condition only. So we are going to vaccinate kids with comorbid condition only, and then on expand it to other kids as well. So that's how vaccinate. But to be very honest, we never ever had vaccine hesitancy or anti-vaccine campaign in India. People here are wanting to have vaccine more and more.
Muito obrigado, Dr. Sunil.
Thank you, Dr. Sunil. Raina, we are approaching the end of our webinar. I would only like to ask a very last question to both of you. We had a peak in the number of cases both in Brazil and India in the first quarter of 2020, and we established a series of measures, and we already had in the first quarter of 2021 in India, in April, May, we had a new wave, a new peak in infections. The question is, will we have to live with these peaks and troughs, or there's a possibility to actually eliminate coronavirus once and for all, or at least for a longer period of time, without these peaks every year or every 6 months? How do you see the possibility of coronavirus elimination measures to be long-term? Would you like to start, Dr. Raina, please?
I'm of the opinion that every country across the world should think elimination. It shouldn't think of living with the virus. That's not the way to go with this virus. And the best way to elimination is to reduce the numbers, keep reducing the numbers. Now, when we saw India's second peak, so despite the fact that we put a large blame on the fact that Delta may have been the responsible factor for creating the second wave, but I keep saying it, that the initial part of every wave will be led by the current circulating vaccine. It won't be the new vaccine, or it won't be the new virus or new strain of the virus. The initial part of the wave will be because of the currently circulating virus strain only. So the key is probably to keep the numbers to as low as possible. So how do we keep the numbers to as low as possible? So in the event of the fact that we have opened up, this is something that is a reality now. We have opened up. So the best way to keep the numbers to as low as possible is to adhere to the guidelines. So if there are guidelines for shopkeepers, they need to be adhered. If there are guidelines for shopping malls, they need to be adhered. If there are guidelines for schools, they need to be adhered. If there are guidelines for individuals, I see this happening in my part of the country as well. As the numbers have gone down, the precautions have gone down as well. As the numbers were up, the precautions were up also. So you see people now roaming around without masks or not using masks correctly. Even if they are carrying the mask because of the fact that they fear that they will be fined, they carry the mask, but the mask is not worn correctly. The shops have opened up, and as I kept telling people in my state that we don't need, I live in a state which is quite hilly in sense, and it doesn't have huge temperatures. So I keep telling my people in my state that we don't need air-conditioned shopping malls. We don't need air-conditioned shopping centers. So we can, at some point in time, open them up. We don't need these. So probably adhering to these guidelines, putting restrictions on the movement of people, not thinking that it is over, will be the key. And elimination is the only way to think about this pandemic. Now, there is no other way of tackling this pandemic. Because if we don't think of elimination, if we let people start living with the virus, there is always a chance that we will have the numbers going up, we will have the new strains coming up, and then there are a peak again. And then there will be the trough and peak again. So we need to keep thinking elimination, and strictly adhering to the guidelines will be the key. The COVID appropriate behavior should be the guideline for all of us to follow for next 5-6 months at least.
Muito obrigado, Sunil. Camila, por favor.
Thank you, Dr. Raina. Camila, please. Yes, no doubt that keeping precautions is one of the very first things to keep in mind for elimination. All experiences in reopening experiences in countries that started to eliminate the use of masks, they had to step back. So the wearing masks must be a daily measure, not only to eliminate COVID, but also wearing masks will avoid a series of other respiratory viruses. Children got sick much less during our last winter. The indicators of severe respiratory diseases were down throughout the winter, and that's not because the diseases were no longer present, but the use of masks will prevent transmission. And this is how we will eliminate not only COVID, but these preventive measures or precautions measures, as I mentioned, are about hygiene, about respiratory etiquette. So they must be here throughout the fight against COVID and other diseases as well. So I believe that this is one of the strategies that must be communicated, and it would employ an important cultural change. I have no doubt that a comprehensive immunization process is a way to eliminate the virus. What is a comprehensive immunization process? Well, we do have 2 doses of vaccine. What is the resistance against it in face of a likelihood of a new wave? We must go after findings about the immune response and virus transmission to walk towards elimination from the incorporation of the immunization process in our regular vaccine calendar, in the same way we did with all other diseases that are part of our immunization calendar, such as H1N1 and the flu vaccine. We have to think of including, of reforming our immunization calendar. I was envious, when you talk about 200 million doses delivered in 1 month. Here we count doses every day to check how many people we can vaccinate on that particular day. We have to think this process more strategically to incorporate COVID immunization in our regular vaccine calendar. Well, thank you, Camila. The message seems quite clear. The World Health Network and the CoVida network in Brazil, we're all focused on that, because we know that we must eliminate the virus. We can no longer accept living with the virus, with the hundreds of deaths every day, people infected with COVID. This is not acceptable. So preventive and protective measures are still necessary. We cannot allow a small fire, because it might become a very large fire. This is the analogy we've been using. So we should hold on to our determination to go after eliminating the COVID pandemic throughout the world. I'd like to thank so much you, Dr. Sunil Raina, who is a member of the World Health Network, and Camila, Under Secretary of Health in Niterói, and wish you all, thank all the audience as well, and wish you all a very good morning. And wish you keep on fighting against COVID successfully. Thank you so much. Goodbye.
Thank you.
Obrigada. Abraço.
Recording